Have you ever stared at the brachial plexus diagram and thought, "Our five roots, three trunks, six divisions, three chords, and multiple branches"? It's like trying to untangle a massive ball of virus. In this video, we're diving deep into the brachial plexus, breaking down each root, trunk, chord, and branch in a way that's simple, clear, and practical for USMLE prep. You'll learn mnemonics, diagrams, structure, functions, and real-world clinical correlations of brachial plexus that will help you understand and retain this vital topic. So, let's get started. What is the brachial plexus? Let's start with the basics. The brachial plexus is a network of nerves that originates from the C5 to T1 spinal nerve roots. These nerve roots come together and form the trunks, divisions, chords, and branches. The brachial plexus is responsible for the sensory and motor innervation of the shoulder, arm, forearm, and hand. It's what allows us to move our arms and feel sensations in our upper limbs. Clinical relevance. Understanding the brachial plexus is vital for diagnosing nerve injuries that can occur in trauma, like a car accident or shoulder dislocation, and can also help with conditions such as thoracic outlet syndrome or carpal tunnel syndrome. Structure of the brachial plexus. Let's review the structure of the brachial plexus. I'll break it down into 5 steps. Roots. The 5 roots C5, C6, C7, C8, and T1 originate from the cervical and thoracic spinal cord. Trunks. These roots combine to form 3 trunks, upper, middle, and lower. Divisions. Each trunk divides into an anterior and posterior division. Chords. These divisions rejoin to form 3 chords, the lateral, posterior, and medial chords. Branches. Finally, the chords give rise to 5 major branches: musculocutaneous, axillary, radial, median, and ulnar. It sounds complicated, but I'm going to break down each part with simple tips that will make it easier to remember. The 5 major branches of the brachial plexus. The musculocutaneous nerve. Origin. Lateral cord C5, C6, C7. Motor function. The musculocutaneous nerve controls the flexor muscles of the arm, including the biceps brachialis and coraca brachialis. These muscles are responsible for elbow flexion and supination, means rotating the forearm. Sensory function. It provides sensation to the lateral forearm. Think about the outer part of your forearm and the back of your thumb. Mnemonic. Muscles flex the arm and musculocutaneous makes the cut. This can help you remember its role in flexing the arm and providing sensation to the forearm. Clinical relevance. Injury to the musculocutaneous nervoflexion and loss of sensation along the lateral forearm. The axillary nerve. Origin. Posterior cord C5, C6. Motor function. The axillary nerve innervates the deltoid and teres minor muscles. These muscles are responsible for shoulder abduction and external rotation of the arm. Sensory function. The axillary nerve also provides sensation to the lateral shoulder, often referred to as the regimental badge area. Mnemonic. Axillary X for the deltoid. Visualize the axillary nerve cutting through the deltoid muscle, which helps with abduction. Clinical relevance. Injury to the axillary nerve, for example, the axilla from a shoulder dislocation can result in weakness with shoulder abduction and sensory loss over the lateral shoulder. The radial nerve. Origin. Posterior cord C5, C6, C7, C8, T1. Motor function. The radial nerve controls the extensor muscles of the arm, including the triceps brachioradialis and muscles of the posterior forearm. These muscles allow you to extend your arm at the elbow and wrist. Sensory function. It provides sensation to the posterior arm, posterior forearm, and dorsal hand except the fingertips. Mnemonic. Radial equal sign rate for extension. Think of the radial nerve helping you extend your arm and wrist. Clinical relevance. Injury to the radial nerve can result in wrist drop and loss of sensation along the posterior arm and hand. For the median nerve, origin, lateral and medial cords, C5, C6, C7, C8, T1. Motor function. The median nerve innervates most of the flexor muscles in the forearm and is responsible for wrist flexion, finger flexion, and thumb opposition. Sensory function. It provides sensation to the palmar side of the hand, especially the thumb, index, middle, and half of the ring finger. Mnemonic. Median equals sign, middle of the hand. Remember that it controls the thumb and fingers in the middle of the hand. Clinical relevance. Injury to the median nerve can result in carpal tunnel syndrome, which causes tingling and weakness in the thumb and fingers, as well as difficulty with thumb opposition. 5. The ulnar nerve origin. Medial cord C8 T1. Motor function. The ulnar nerve innervates the intrinsic muscles of the hand, responsible for fine motor control, like gripping and pinching. It also contributes to wrist flexion. Sensory function. The ulnar nerve provides sensation to the medial side of the hand, including the pinky and half of the ring finger. Mnemonic. Ulnar equal sign. You'll need your pinky. This helps you remember the ulnar nerve's role in the pinky and part of the ring finger. Clinical relevance. Injury to the ulnar nerve can result in claw hand, a condition where the fingers are bent into a claw-like position due to weakness in the intrinsic hand muscles. Clinical correlations. Here are some key examples. Erb's palsy. It results from injury to the upper trunk, C5, C6, commonly during childbirth or trauma. Patients present with a waiter's tip deformity, where the arm is adducted, internally rotated, and the forearm is pronated. Klemke's palsy. It is caused by damage to the lower trunk, C8, T1, often due to hyperabduction injuries. Patients present with a claw hand deformity due to intrinsic hand muscle paralysis. Radial nerve injury. It is typically caused by midshaft humerus fractures. It leads to wrist drop, characterized by an inability to extend the wrist and fingers. Carpal tunnel syndrome. It is compression of the median nerve at the wrist, causes numbness, tingling, and weakness in the thumb and first three fingers. Ulnar nerve compression. It is often seen in cubital tunnel syndrome, resulting in numbness in the ring and pinky fingers and difficulty with fine motor tasks. Question of the day. A patient comes in after a car accident and has trouble lifting their arm and complains of numbness on the lateral aspect of the shoulder. What nerve might be affected? Only a genius can answer in the comments below.